First of all, trigeminal nerve is a cranial nerve that provides skin of the face with a sense of touch, temperature, and pain. The third branch of the nerve also provides motor function to the muscles of mastication. There are two trigeminal nerves, each on one side. As the name of the nerve implies, it has three branches. It originates in the brainstem and shortly divides into three branches. The first branch is responsible for sensation of the forehead and the region above the eye. The second branch is tasked with sensation in the upper jaw, and the third branch deals with sensation in the lower jaw. Patients describe trigeminal pain as sudden attacks of excruciating pain on one side of the face, affecting a specific area in each or several branches of the nerve. There is no pain between attacks. Pain can be provoked, amongst the other factors, by touch, talking, smiling, eating, brushing teeth, shaving, cold air, and wind. Therefore, patients often develop behaviors that limit facial movements. Pain can spread in one or two, rarely in all three branches of the nerve. Generally, periods of pain are replaced with periods of remission that can last months, sometimes years long. Since symptoms may seriously affect the life of patients, it is considered to be a debilitating disease. Disease affects women more often than men and typically manifests between 40 and 50 years of age. However, it's not limited to this age group. What is the cause of trigeminal neuralgia? The common misconception is that nerve can be damaged by wind, cold weather, or somehow else be frozen. However, cold can be a provocative factor, but it is not the cause of disease. In up to 80 to 90% of all cases, trigeminal neuralgia is caused by pressure of an adjacent blood vessel on the trigeminal nerve, a so-called neurovascular conflict. How is trigeminal neuralgia diagnosed? One of the criteria for diagnosis is typical pain itself. Since trigeminal neuralgia presents with quite typical clinical features, a clinician should be suspicious based on the presentation only. This means that a comprehensive history of the patient involving specifics of the pain, its nature, affected region, and duration can be sufficient to raise the doctor's suspicion of the diagnosis. A magnetic resonance scan of the brain is needed to confirm the diagnosis. Images of an MRI scan can demonstrate if a nearby blood vessel is pressing down on the nerve. A diagnosis can be established if the patient has both of the following: typical symptoms and established conflict between the nerve and the vasculature demonstrated by magnetic resonance imaging. How is trigeminal neuralgia treated? Trigeminal neuralgia in vast majority of the cases can be treated effectively by medication. The most common medication used are carbamazepine or oxcarbamazepine. Surgery is limited for those patients who are not happy to take medication lifelong, or to those who develop significant side effects from the medication, or for those to whom medication is not effective. Surgery is very straightforward. It involves incision behind the ear on the affected area. A small opening of the skull is created to gain access to the intracranial nerves. The aim of the surgery is to take the pressure away from the nerve. A specific medical grade Teflon is inserted to separate nerve from the adjacent vessel. Effect of the surgery is immediate. Patient wakes up after surgery with no pain whatsoever.